Okay. Good afternoon, and thank you to everyone to inviting me to this Preciseo program session. My name is David Dalmau, and I speak today from a clinical and system perspective, working within an integrated health system in Catalonia that covers around 300,000 people across primary care, hospital care, mental health, and long-term care. These give us a unique opportunity and responsibility to connect population-level data with real clinical practice. And I would like to focus on a simple but critical question. How do we move from climate awareness to clinical action, and on the understanding that climate change is already shaping clinical outcomes, yet health systems remain structurally unprepared to anticipate and manage this risk? The next slide, please. Health systems are not integrating climate risk into clinical decision-making, despite the strong and growing evidence. Over the last years, evidence linking climate exposure to health outcomes has become very robust. We know, for example, that heat increases cardiovascular events, respiratory exacerbations, and mortality. Next, please. But importantly, this doesn't affect everyone equally. Most of the burden concentrates in people with chronic conditions who represent around 80% of healthcare demand in our systems. The next, please. If nothing changes, we are not only facing increased morbidity and mortality, we are also failing to protect those we already know are most vulnerable and persisting with gap between policy and real-world impact. The next slide, please. We generate evidence. We don't operationalize it. This is not a lack of evidence. I mean, it is a failure of integration. The next slide. Concerning policy architecture, we have frameworks. We have national and regional heat health plans. They are effective in generating alerts and guiding public health responses, but they are not connected to clinical decision-making at the individual level. Next slide. We also have increasingly rich health data systems. In our case, we can integrate clinical, administrative, and environmental data across an entire population. But even in such settings, this data is rarely translated into actionable tools for clinicians. The next slide. And concerning green strategies, we have a strong sustainability and mitigation strategies, but these often remain disconnected from clinical adaptation. Next. Therefore, framework exists, but they don't operate as a system. They act in parallel, not in integration. Next slide. If we look across the system levels, the patterns is remarkably consistent. Climate risk is simply not embedded in routine healthcare decisions making. In terms of governance and regulation, there is no mandate to integrate climate risk into clinical care, or prevention and anticipatory care are not incentivized. Data systems are not interoperable or translated into decision support tools, and clinicians don't yet perceive climate risk as part of their core responsibility. The next slide. In summary, the system is structurally reactive and not designed to anticipate risk. Next slide. So the key question is, can we operationalize this in a real systems? In our setting, we are working with an integrated population of around 3,100 people. We combine clinical data with high-resolution environmental data to identify which patients are most vulnerable to heat-related health events. Next slide. This has been possible thanks to the creation of a consortium with different stakeholders created at the end of 2023, which give the consortium integration, complementarity, and added value from different expertise. Next slide. First, we use retrospective population data to quantify risk and identify vulnerable profiles, particularly, particularly among patients with chronic conditions. Then we translate this into action, activating preventive pathways during heat events. These include identifying high-risk patients, adjusting care, and coordinating with primary care and community resources. We are also exploring complementary dimensions of vulnerability, including housing conditions in older populations and biological susceptibility through epigenetic studies, which reinforces the need for integrated approaches. These allow us to move from population-level alerts to patient-level action. Next slide, please. Bridging data and care pathways enables anticipatory healthcare in real-world settings. Next slide. This approach has already been recognized at the European level, for example, through policy brief from the European Observatory on Health Systems and Policies, where we were one of the hospitals selected as an example of how reduce the environmental footprint and contribute to more sustainable health systems. Next slide. If we look at national heat health plans in countries like France or UK, they work at a population level, but they don't translate into clinical action. They improve preparedness, but they don't systematically reach individual patients. In the next slide, you can see several examples in literature that demonstrates this gap from some Horizon projects, from some published from the 2025 Lancet Countdown Europe, or from Santé Publique en France or ES Global in Barcelona. The next slide, please. Thus, population preparedness does not equal clinical integration. Health equity should be the compass for climate resilience, because without integration, the most vulnerable remain unprotected. Therefore, scaling without integration limits its impact. Next slide, please. We understand the problem. We know why implementation fails, and we also know what needs to happen next. So what do we do next? Some actions can start immediately within health systems. Others require policy and system-level transformation. Next slide. Implementation is not an innovation problem, it is an alignment problem. And next slide, please. This is the Barcelona document based on the symposium held in the University of Barcelona last October and on discussions with policymakers, clinicians, and researchers. We have consolidated these priorities into the Barcelona Call to Action, a practical document designed to support implementation across different contexts. Through this QR code, you can access to this document, and I would encourage you to explore how these actions could be adapted to your own system. The key question is not whether these actions are relevant, but which of them can be implemented in your system starting now. Next slide, please. Finally, if we want implementation, we need to measure it. And these are three indicators that allow us to track progress, from identification of risk to reduction of outcomes or an activation of preventive care. Next slide. So how do we move from population-level alerts to patient-level clinical action? What gets measured can be implemented. Thank you very much for your attention.